Edgar Ordóñez, soy neurocirujano. Estoy haciendo la dirección de estos webinars. Hoy tenemos el placer de estar con el doctor Mitch Berger, que es un neurocirujano muy reconocido a nivel mundial. Así que vamos a hacer la introducción en inglés. Esta charla es en inglés. So, Dr. Berger, thank you very much for accepting this invitation for this lecture. So I will do a brief introduction of Dr. Berger. So he completed his bachelor's degree at Harvard College. Then he completed his medical degree at the University of Miami and finished his internship and his residency at UCSF. Afterwards, he also did his clinical fellowship in neuro-oncology, also at UCSF, and completed his clinical fellowship on pediatric neurosurgery at the University of Toronto. He has a large number of publications on brain mapping and neuro-oncology, including books, book chapters, journal articles, including the most renowned journals of neurosurgery, including JNS, neurosurgery, etc. So his main clinical interest and expertise is on treating brain and spinal cord tumors, as well as tumor-related epilepsy in adults and children. So he's a specialist in brain mapping techniques that are used to preserve motor, sensory, and language areas during surgery using cortical and subcortical stimulation, and also using advanced MRI techniques for radiological brain mapping. He's also expert in using the Gemini for complementary treatment for these tumors. So Dr. Berger, congratulations for your completed 23 years tenure as chair of your department. So yeah, it's a big accomplishment on your career. So congratulations for that. So he's now the director of neuro-oncology surgery program at the Tumor Research Center at UCSF. He's also director of the Brain Tumor Research Center and director of the Center for Neurological Injury and Repair. So I had a chance to meet Dr. Berger for the first time in Chicago at the AANS 2016, and this picture was Los Angeles, also for the AANS meeting. So Dr. Berger, again, it's a pleasure and an honor for us to have you with us. Please go ahead with your presentation.
Okay, well, I'm going to try to get the slides up, but Edgar, thank you very, very much. It's a great pleasure for me to be asked to give a talk to all of you and to share ideas. It's a very complicated time in the world today. We still cannot go outside to any places to eat or to drink or to have a movie or anything like that. We just can go to work and come home. And we have had much in the way of fires in California, very, very difficult time. So last week on Tuesday, it was dark all day because of the ash. And now it's starting to clear after a week. So it's very complicated. And I wish I could invite you to come to San Francisco and to see our beautiful city. Some of you may have been here before. We have usually the CNS or the WNS meeting here. So I'm looking forward to having Edgar come visit me and to work with us and learn the brain mapping techniques. And then what would be my great pleasure is for me to come to Bogota or other great places in Colombia and to visit. Many years ago when I was in college, I had an opportunity to go to Bogota and it was beautiful. I went to Cartagena, Bogota, San Andres.
Wow.
Uh, it was one of the most beautiful countries I've ever been to. And I'd like to go back at some point. And so we hope, travel will be restored one day. But so I look forward to having you come here, and I'm going to go there and have some really good coffee.
Absolutely.
Yeah.
Absolutely. Thank you very much for that.
So I'm going to spend some time talking about some things here. And I want to start by sharing a journey with you. This is a journey that I've taken to get to where I am today. And it all starts with a situation in which I was a resident in San Francisco, and I was learning from the great master, Dr. Charlie Wilson, about how to be a tumor surgeon. But I realized after seeing many cases that did not go as well as I would like to have seen, that there had to be something different about the tumor resection that had to encompass functional understanding of the brain. So when I finished my residency, I had the chance to go to the University of Washington, and soon I met Dr. Ogerman, who is an epilepsy surgeon, and he was very interested in functional mapping, but was only interested in mapping the surface of the brain. And of course, for tumors, we have to worry not just about the surface, but the undersurface or the subcortical pathway. So this was a very, very important time for me to be able to go and to learn about functional organization of the brain. Now, prior to the time I began my career, which was in 1987, there was really not much published on brain mapping as it related to removing tumors. So I did not have much to go on, and I had to essentially develop this strategy as I went along in my teaching. And I had the ability when I was a college student at Harvard to take a course by Dr. Geschwin, who is very famous, and he was a neurologist who spent time looking at post-mortem specimens after stroke, and taught something very, very interesting, that the brain was connected, that there were different regions of connection. And he was the first one to really point out the connection between Broca's area and Wernicke's area through a fasciculus we now call the arcuate fasciculus. And this resulted in the ability to describe syndromes that occur following neurosurgical procedures or injuries to the brain. What I did not understand at the time was the concept that there would be the ability to predict plasticity of the brain. I didn't understand this concept, meaning reorganization. And I'll come back to this because I think it's a very important concept for us as neurosurgeons. But he was the first one to really start talking about plasticity in the brain. As time went on in the 1950s and 60s, mapping became something that neurosurgeons were starting to do. Dr. Penfield at the Montreal Neurological Institute started doing this and began to publish composite maps of the brain showing different areas of language organization, very basic. But again, at this point in time, we did not understand the subcortical systems from a mapping point of view, only from postmortem autopsy. The other reason I got into this, I'm not sure about these lines here, but it's okay. The other reason I got into this, And if any of you were at the AANS meeting in 2013 in New Orleans, I was the president that year, and I talked all about patient safety. To me, I've always been very, very concerned with being able to do a very safe operation. So everything started to fit together in my career very nicely, that I was going to promote a very aggressive extent of resection. And during that time, I was going to be as safe as possible. This was, let me just go back. Yeah, this was the process by which I assessed my progress many years ago. I published this article in the Journal of Neurosurgery, which showed, and I think it's important to show all of you, because as you begin to be involved with this technique, you begin to realize that there is a learning curve. But the question is, do you continue to get better, or do you begin to deteriorate in terms of your ability to perform safe radical resections? And so this was very, very important that I begin to assess my own ability to do that. I published this paper showing that not only could I continue to do this safely, but that I was continuing to do a more aggressive resection volumetrically year by year. So every year you do this, including now, and I'm 67 years old. So I continue to learn, and I continue to do better now than I did 2 years ago or 5 years ago. So it's an important thing to keep in mind. And the other aspect of this, and I think one of the reasons why I enjoy doing a talk like this, is to be able to teach, because this is a very important study that was published last year, which asked the question, unlike in my experience where I had no teacher for this, except Dr. Ojerman to teach me about functional localization, that if you have teachers that can help you, like myself, or Hugh Defoe, or others who work in this area of functional mapping and tumor resection, that we can show you how to do resections as good as we do them early in your career. So in other words, when we compared the experience myself and Dr. Defoe have with the junior surgeons who we teach how to do extensive resections with functional mapping, we see that the junior neurosurgeons actually achieve very similar results as the senior level neurosurgeons. So it's very encouraging to know that we're able to take this very complicated technology, teach it, and have the younger generation come along and be able to do aggressive resection. So this was a very important article. So why do we do this? Why do we insist upon an extensive resection of high-grade gliomas, low-grade gliomas? Because we know that the extent of resection affects survival. That's really exactly why we do this. And of course we do it because we want to be safe, and the mapping techniques allow us to be safe. And that's what this talk is going to be about. It's going to be about how do we do the technique? How do we do this to enhance safety? And then at the end, I'm going to show you how you can take this technique and use it to do things that potentially at this point in your career, you may not feel comfortable doing. We'll come back to this in a minute. So we know, as you know, that we have many, many wonderful technologies in neurosurgery now, but no matter what we do, and the anatomy is not as important as the function, meaning we have to understand function. We don't need intraoperative MRI. What we need is the ability to stop when we see function. And this is really important. You'll see this through the course of this lecture. And the importance of brain mapping, I think we all realize, and it's been something that's been really the fundamental component of my career as a tumor surgeon. And one of the things I learned early in my career based on this article that we published in 1989, this was the largest study ever done looking at localization of language in the brain, is that the amazing thing was, and even to this day, having operated now today on patients with mapping, that there is tremendous variability in the localization of language in every human being. So no two humans are alike. So we have to map language function repetitively. In the study that we published back in 1989, we also learned that and this was something that was very important, we learned and we taught others that we needed to do very large extent of cortical exposure because we felt that the mapping technique had to be positive to allow us to do a safe resection. In other words, we were very concerned about having a negative map stimulating the cortex, not seeing any function, and then doing the resection. So we talked about the fact that entirely negative mapping was not helpful and you could not use that. And you'll see how things have changed in my career. First point I wanted to make is the variability. I talked about how variable language function is. And this study that I published a few years ago proved this very, very critical point. Basically, it was a study where I went back along with my colleague, Dr. Eddie Chang, who now is the chairman of neurosurgery at UCSF. He's a very well-known functional surgeon as it relates to epilepsy and functional language localization. He and I put all of our cases together based on navigation, saved every point, and then developed the probability and variability of finding functions. So for example, if you wanted to know what the probability of finding speech arrest was, this is where you would expect to find it. But you can see the variability is huge. You would never expect to find speech arrest in the superior temporal gyrus, but it can occur. Likewise, for naming, there is the probability that you're going to find this in the region that we call Wernicke's area, but on the other hand, there's a great variability, and you can find naming function even in the inferior frontal gyrus in the frontal operculum, which is very unusual, pointing out again that you need to map everybody, especially when people speak more than one language, because the language can vary. And the sites can vary depending on when you learn the second language. So now the other point I wanted to make was that now toward the end of my career, I now realize that negative mapping can be relied upon in planning a surgical resection, that it's okay to do a very focused exposure and to not have a positive site, and then to go in and do the resection based on that. And I'll show you what I mean by this. And the reason we proved that this was okay is because we looked at cases when we published this article in the New England Journal of Medicine, that if we did a small exposure and did a resection, that even though temporarily there were deficits, the long-term permanent morbidity was very, very low. So this was very acceptable. So we know if a patient's going to have a deficit, we're not going to be able to predict that until 3 months out. For the first 3 months, things can be different. And if you're wondering, is there any difference in a left-handed person when we map the right side of the brain? The answer is no. So we've published very similar localizations and variabilities of language in the right-sided left-handed patients as we see on the left side with right-handed patients. And then the final point to make about this before I get into some of the technical aspects is the fact that if you do this work, you can expect that patients do not look very good immediately post-operatively. If you test all of their language functions within 2 to 3 days of surgery, they all have deterioration compared to baseline. And this gets better typically within a month, and certainly, as I showed you, within 3 months. you can say that's where the patient's going to be 3 months out. So it's a very nice time frame, and it's also very important to be able to say to the patient and their family that we know you're going to be okay. We did the testing, everything was fine. This is all swelling and manipulation of the brain that causes transient aphasias. Okay, so I think you have to realize now that the ability to do a safe resection is really linked to the use of mapping. And in fact, if you want to reduce the morbidity by half, we have shown based on this analysis we did a few years ago, that if you use stimulation mapping, you can reduce the risk of a deficit by 50%. Very, very important. And we showed this in my experience, in Hugh Defoe's experience, in Philip DeWitt Hammer's experience. He's in the Netherlands. We all have come to this conclusion that if you're going to be aggressive with a resection, you need to do it with mapping. Okay, so let's talk about this. And I think in particular, the awake craniotomy is probably the most important part of mapping that you can do. I've now done more than 1,500 of these cases. I think things slowed down a little bit during the COVID period. Since January, I've done another 45 cases awake, so I'm up near about 1,550 in awake cases. And I've learned a lot during this time, and I'm going to try to share some of this with you. Certainly, the type of patient you choose, it can be any patient, but you need to counsel that patient, discuss the type of surgery you're going to be doing with the patient awake beforehand. You have to choose the type of anesthesia drugs you use. Some weeks I use a laryngeal mask and put the patient to sleep and open up, and other weeks I don't. It just depends on the patient and what they're comfortable doing. Local anesthetics are important not only in the skin, but in the dura, and we do very focused exposures, and then we do the motor and language testing, and basically any testing you want. If you're working in the right parietal lobe and you're worried about an apraxia of motor function, you can have patients do motor tasks during the course of this procedure to make sure that they're not losing their ability to do fine motor movements. And remember, doing tumor surgery, you have to do both cortical and subcortical mapping. And in my career, I've learned that there are a lot of issues that may make you think that you can't do mapping, but the reality is you can do mapping on anybody, even patients who are 10 years of age, sometimes slightly younger. And you can find solutions for these patients. So for example, in a patient where you're worried about intraoperative seizures from stimulation, you could use iced Ringer's solution. That iced solution we reported in the Journal of Neurosurgery several years ago is a great way to stop seizure activity from occurring. So these are all the concerns you might have had about mapping, but these are the solutions to get you through that process. And I like to use the asleep with or without a laryngeal mask, wake the patient up, do the mapping, and then put them back to sleep or keep them awake for subcortical mapping. This is how I do it. And when I do the testing, just to show you the little animation here, we look for the motor cortex, the sensory cortex, we look for speech arrest, we look for naming, reading, and any other function on the surface that you're interested in. And then we do these resections. And then I'll come back to this when I talk about insular tumors. So I'll just skip this for a minute. The anesthetic regimen that I currently favor is the use of dexametastomidine and remifentanil, or the use of propofol and remifentanil. These are really good drugs and allows you to really do everything you need to do with or without a laryngeal mask. If the patient has a lot of mass effect, sometimes I'll put in the laryngeal mask, get it open, take it out quickly, do the mapping, and then put it back in to hyperventilate the patient. So you just have to be flexible. And as I said, the exposure, which used to be very, very large, is now often very small. We call it a focused exposure because it's okay to have negative mapping. And sometimes you have to change the anesthesia regimen. Like last week, I was doing a case and I started with propofol and remifentanil, and the patient didn't tolerate it, became anxious. The dexamethasone didn't work. So we stopped, put in the laryngeal mask, opened it up, and then awakened the patient to do the mapping. So you have to be flexible. And 42% of the time before I make a skin incision, we will definitely change the anesthesia. The risk of stimulation-induced seizures is still very minimal, very acceptable, 2%, but with the ice ringer solution, we never have to abort or cancel the operation. And still, in my experience now, with over 1,500 awake craniotomies, my risk of a late deficit is still about 2%, which is great. It's not zero, but there's only about a 2% of a permanent deficit. Now, remember, I showed you that about 50% of the time, patients within 2 days get really bad, and then by a month, they're better. But by 3 months, the risk is somewhere around 2%. Very acceptable. Okay, when we have a postoperative problem, we can either wait and see if the patient gets better, or we can do some things to try and make sure we don't have a permanent deficit. This is an article we published in April showing how we use postoperative diffusion tensor imaging to determine if a patient's having a problem like a semantic paraphasias or phonological paraphasias. Postoperatively, we do the DTI to find out if we have injured or resected part of the pathway. And this allows us to determine how long this deficit is going to last. If we've transected the entire pathway, we know that may not come back, but if it's only partial, we know it's going to get better. So postoperative diffusion tensor imaging is important to rule out injury to a tract, and postoperative diffusion weighted imaging is very important to rule out a postoperative stroke as a cause for an injury. If you're interested to learn more about this, in the Journal of Neuro-Oncology this year, we have a review article describing our technique and which functions we map, including subcortical mapping in the Journal of Neuro-Oncology. It's a very nice review on awake surgical mapping I refer you to. If you don't have the journal, I'm glad to send the article to you. One of the interesting things I learned about this article is that if you look at everybody from around the world who does this work, I still think there's too much variability. Too much variability here. You can see the differences in permanent deficit rates, for example, in my experience versus in other experiences. And it just goes to show you that not all of these techniques are standardized. So this is why in a lecture like this, I think is important, because after 1,500 cases, I know what it takes to be able to get to 3% as a permanent deficit rate. Very important. Okay, so here are the basic principles of awake cases. We do scalp blocks around the incision. We use iced ringer solution while we're mapping to prevent seizures. If there's pain upon infiltrating the dura, we infiltrate it with lidocaine or marcaine. These are nice little tricks to think about. This is the setup in my room, what it looks like. We have the surgeons here, nurse there, We have the neurophysiologist here with a drape over here. And we have the stimulator here, the ECOG, corticography mapping here, navigation. And we don't use intraoperative MRI in San Francisco. I would like to do it. We have issues with earthquakes, as I'm sure you do, so we don't have stability for that. So we're working on that now, but to build a different facility. These are the tests that I use. Very simple. Picture of an animal or an object. That tests object naming and reading. And in fact, those two tests are the two most important tests to predict a postoperative deficit. If you have a patient who can name these tests at the end of surgery, then the likelihood of a permanent deficit essentially sits underneath 2%. So it's very, very important to use these tests. And we have tests now to test subcortical language function. So for example, this is an article we wrote in Brain and Language last year showing the two most important tests you can use for subcortical mapping. So for example, in the ventral stream of language subcortically, meaning the inferior frontal occipital fasciculus, in order to find that subcortically, you can do one of two things. You can show a patient these pictures, and you can ask them to name the object of the picture that is either related or unrelated. So you can show them this and say to the patient, name the object of the animal that shows up in the picture. So this eliminates, if they say horse, picture word interference. You can do this related objects or unrelated objects. I like to use unrelated objects because this presents some confusion. Or you can stimulate subcortically and look for semantic paraphasias upon stimulation. For the posterior or dorsal stream, meaning the arcuate fasciculus or components of the superior longitudinal fasciculus, you can stimulate the white matter and look for stimulation-induced phonological paraphasias. In other words, instead of saying plane, like an airplane, they say a plum or something like that, phonological paraphasia. And the other thing that we do is we show them a picture of something like this in action, verb, subject, action. So they have to say, while I'm stimulating the white matter, the couple are dancing. She is writing a letter. Very simple. But if they can't tell me this, then I know I'm in the dorsal stream, meaning the arcuate fasciculus or the SLF. And this is how I tend to do my resections. I use the stimulator in my left hand. I use the cavitron in my right hand. I stimulate, patient's awake, I cavitron, I stimulate, I keep going on and on and on and do the mapping this way. And if you're interested to learn more about the subcortical organization of language, I invite you to read this article we published in the Journal of Neurosurgery a few years ago, which very, very nicely shows you everything you need to know as a neurosurgeon doing subcortical tumor removal. You can even use this when you're doing removal of arteriovenous malformations, cavernous malformations, etc. When Dr. Lawton was with me, I used to do a lot of the mapping for him, show him the best trajectory in, and then he would go transcortical for an AVM or CavMal. And I think that's a very another nice, useful technique. What are the indications for awake operation? Basically everything. When I started my career, I would say less than 5% of my cases were awake. Now, at the end of my career, 95% of my cases are awake. The only exception, as I'll show you, is in certain types of motor mapping. So you can use this technique for frontal lobe tumors like this. go all the way back to motor cortex and speech arrest. You can use this for temporal lobe resections like this. You can use this for the parietal lobe to do resections up to sensory cortex or the back of the sylvian fissure. And of course, you can use it for insular tumors, and I'll come back to this because I think that's an important strategy for that. Let me give you an example of an awake procedure. This is a patient who's right-handed, has language in the left hemisphere. We want to be able to resect a zone 1-4 insular glioma. This is the classification scheme that's used now. And so how do we do this? We first map with the patient awake, testing, reading, language, and then we know that the suprasylvian area is quiet, as is the infrasylvian area. So we're first going to remove the frontal operculum, and then we're going to go down through the tumor, working deep to the insular vessels. And then eventually we're going to have to work on the other side of the sylvian fissure. We do subcortical mapping, and we continue to resect this until we join these cavities up. And you can see both suprasylvian, infrasylvian, middle cerebral M2 branches, and the first insular branch that we've now joined up. And you can see on the postoperative image that we can get all the way up here. This is post-op. We can go up here, go all the way down here, and then we can join the uncinate fasciculus to get underneath the insular branches, the middle cerebral, the M2 branches, and do a very nice resection of a tumor like this. Okay, let me say something about a sleep mapping because the technique has evolved. And recently, and I think Edgar, you showed a slide of a paper that we recently published describing a new technique called the triple motor mapping technique. When I started my career, I was using primarily low frequency bipolar stimulation, 60 hertz, very, very effective with simultaneous EMG that I described back in 1999. And this very nicely can find the subcortical motor pathway. Very nice to do a resection like this in the supplementary motor area with strip electrodes to find the leg motor cortex, mapping back to the motor cortex here and getting all the way up to the motor strip. So when I analyzed my data 2 years ago, I started to realize after 700 cases of using bipolar stimulation mapping that I was still starting to see that there was a low risk of a very severe permanent deficit with the bipolar mapping. And the reason why it turned out that all of those injuries were from ischemic injuries. So in other words, the bipolar stimulation, which is very focused mapping, was getting me too close to the subcortical pathway. And if I looked at my severe deficit risk, if I found the subcortical pathway, it was 4%. So to me, this was too much. So I decided to embark on a new strategy where I would use bipolar 60 hertz low frequency stimulation to get right onto the motor pathway. And then I would use monopolar high frequency stimulation to get within 2 centimeters of the motor pathway. And then I would use transcortical motor stimulation to stimulate through the scalp or to put a strip electrode on to find the integrity of the corticospinal tract. So now with bipolar, monopolar, and transcranial motor stimulation, I have 3 ways to map the cortex. And we published this and showed that in the first 60 cases where we used all these techniques, like I did today, for example, in a cingulate gyrus tumor working under the motor cortex, that the likelihood of a permanent deficit in those 60 cases was only 1, and that was just a 4/5 deficit from a small degree of ischemia. So I was able to walk right up to the pathway. Today I got to within 3 millimeters of the pathway using monopolar and bipolar stimulation. Very, very nice. So that's how I do motor mapping now. And this is the article if you're interested in going to the Journal of Neurosurgery. If not, I'm glad to send it to you. So here's a great example of a sleep motor mapping. You want to do this here because here's the motor strip, DTI motor strip. Okay, so what are we going to do here? We're going to map. So we open the dura. Here's the falx here. We map. We find the motor strip back here. We're going to coagulate the cortex. We're going to resect, continue to resect, and then we're going to find the falx here and take it all the way back until we find subcortical motor pathways descending from the motor strip, which you see right here, number 3. We stimulate with a bipolar electrode, monopolar electrode, get all the way up to the falx, and we can do a really nice resection going all the way back to the motor strip. And so now I feel very comfortable doing a sleep motor mapping to be able to take a tumor like this and take it out back to the motor strip without having the patient awake, going right up to the primary motor cortex. Very, very nice technique, works beautifully. Now, one of the things about the supplementary motor area that has been challenged recently is that some people are saying it's not safe to do a resection because of the potential that you would transect the Aslan tract. And that is the reason for the supplementary motor area. That is not true. And this is a report recently of a case we did. And now we have a study that has been, or soon to be submitted to the Journal of Neurosurgery with over 120 supplementary motor area resections showing indeed that the Aslan tract can be resected. This is the tract that connects the supplementary motor area to Broca's area and is believed to be the reason why patients become mute after a left mesial frontal resection. But it's just a temporary problem, and cutting the Aslan tract is perfectly fine. That's why you don't do these operations awake. Because if you were doing this awake, you would stop because you would stimulate the Aslan tract and get speech arrest. And then you would say, I can't go any further, but that's not true. You can resect the Aslan tract. And you see it here in the postoperative scan showing I've cut the Aslan tract, and the patient afterwards has a brief degree of mutism, and then it gets better. So it's not a problem. Okay, well, let me show you some examples of how the mapping can be used for you as a glioma surgeon to make it safer and to do things that you didn't think you could possibly do safely. Let's talk about getting into a deep-seated glioma. Okay, so I like to think of it as what I call, in other words, my philosophy to all gliomas in all locations is what I call transcortical equatorial approach. So in other words, I will find the distance from the equator of the tumor to the shortest distance to the surface. So for example, if you have a mesial temporal lobe tumor, some of you may come under the temporal lobe. Some of you may come down the sylvian fissure. Some of you may come under the temporal lobe from behind, which was popular several years ago. But I would say it's easier to come for me into the center of the tumor from this point on the surface, but you cannot do that unless you know where the mapping is going to take you. So again, transcortical approach through the cortex after it's mapped. So let's take an example of that. You have a deep-seated tumor here. I'm going to come down through here, but coming through here means I have to find a silent spot near or in the motor cortex. And I do. I find that, and then I map as I go. So I stimulate, I map, I suction, I resect, and I keep stimulating until I find a subcortical pathway. Very important concept. Again, this is transcortical to the center of the tumor, equatorial approach to a deep-seated tumor. So let's look at an example like this. Very difficult case, thalamic tumor, very, very vascular. You may not think of doing the tumor this way, but this is exactly how I would do it, because this is the shortest distance to the center of the tumor. But in order to do that, I need to know this is safe. So I first do the map with the patient awake. I find the sensory cortex. I find the back of the sylvian fissure. I find the area that results in stimulation-induced anomia in the angular gyrus. However, in the supramarginal gyrus, this is silent. So I remove this. Then I stimulate subcortically to make sure I do not injure the superior longitudinal fasciculus, the TP or temporal parietal portion of the SLF. So I can map that, and as long as that's safe, I can go into the tumor, and then on the deep side of the tumor, I'm going to map the internal capsule. So this is the nice way of being able to do a resection like this. Now, when you look at this, this is not a complete resection. It's okay. Doesn't have to be a complete resection. This is about a 95, 98% resection of a complicated tumor in a patient who is awake, dominant hemisphere, who is able to leave the hospital within 3 days of surgery and does not have a deficit, because I don't injure the SLF and I don't injure the internal capsule. So this just shows you how important this technique is. What about tumors in difficult to reach areas? Very, very difficult strategy. I can think of no tumor that's more difficult to reach than the insular tumor. Did a case yesterday, another insular tumor. I usually do 2 of these a week. Patient on the right side, very, very complicated, deep subcortical mapping for motor system on the right side. Of course, on the left side, we're going to do the wake case. So what's the problem with a case like this? The problem is that you cannot reliably split the fissure as far as you want to go. And secondly, there is tumor that goes outside of the insula often. So splitting the fissure cannot get you underneath the frontal operculum. So I like to consider the other aspects of this where I would come through the surface, because you realize that the lenticular striate vessels never go in the tumor, they go inside the tumor. So here's the tumor. The lenticular striates are pushed over here. I'm going to now map the surface. I'm going to resect the cortex that's silent. I'm going to work through my M2 branches on the insular surface, making windows. This is the window technique I described in the Journal of Neurosurgery. And my mesial border is this, the lenticular striate vessels. You see them beautifully here. And once you see the lenticular striate vessels, you never go further. That's the end. So we use the zone classification system for zone 1, 2, 3, and 4. Zone 1 and 2 above the sylvian fissure, zone 3, 4 in front or behind the foramen of Monroe. Zone 1, 2, 3, and 4. This is the current system that allows you to look at a preoperative scan and know exactly where the tumor is. And based on some very nice studies we did with my colleague, Mike Lawton, and now his resident, Arno Bennett, we were able to very nicely show that we could get our instruments into the insular system through these windows using the transcortical approach better than the transsylvian approach. And here's what I mean by that. So going back to that animation, we've mapped the surface. I'm now going to remove suprasylvian, infrasylvian. I'm going to work in between the M3 branches. I'm going to now make windows through the insular surface between the M2 branches. I'm going to now go all the way down here until I find my lenticular striate vessels, and then here, and then I'm going to map the internal capsule here so that you can get all the way close to this region here. This is how I do all the insular tumors on the left side, and on the right side, I do it the same way, asleep without language mapping. Now, clearly there are tumors like this that are small, and they don't need a big transcortical approach, but you have to be prepared for that. So in a case like this, I will have the patient awake. I do the mapping first to make sure in case I have to go infrasylvian or suprasylvian, and then we split the sylvian fissure. I had Dr. Lawton do this case very nicely, and he split the fissure, got me down to the tumor, and then I can now do the resection of this tumor. And you see how big of a split it is. Very nice for something very small. In this case, having mapped the surface, I did not need to go transcortical. So I had the patient asleep while we split the fissure, woke him up, did the mapping, put him back to sleep again, and just went here to do the resection. And this is what the split looks like. And then this is what the postoperative scan looks like. So to me, that's one of the few indications for the transsylvian approach. But as I said, because the tumor goes way out here in the green areas around it, you can't always split the fissure to get to that area. And if you're interested, I would advise, this is part 2 of the validation system, which looks at how you can predict extent of resection based upon the zone. So I know now if I see a patient in the clinic and I have a zone 1 tumor, I can tell them that I'm likely to get a 90+% resection. And this is based on when I published the series in 2016, 244 cases. I now have over 365 insular tumors that I've done, and we'll eventually put this series together once we cross over into the 400 threshold to show that it's still very, very safe to do it, and it's very predictable based upon the ability to really understand where your vessels are, where the language is, and to go transcortical. And if you're interested, this is an article I published in the Journal of Neurosurgery last year, which is a review article on insular glioma surgery, how we've been able to get to this point over the years. It's a beautiful, I think, example of where anatomy and function come together, but function is what you base your resection on. Okay, plasticity, very important concept. I talked about that. Years ago, my colleague who came and was my student when I was in Washington, Hugh Defoe, said to me, I think that plasticity really exists. And he was talking about some of the cases that he saw plasticity occur in the brain. So I didn't really appreciate that until I went back and looked at my own cases that I had remapped. And we published this article showing, for example, when I did the resection and I saw speech arrest, that when I came back 30 months later, I didn't see any speech or anomia. And so in basically 40% of cases, we were able to see loss of function. Very, very interesting in that 40% of the time, if you leave something there in functional tissue, the function can move away. This is principally for the cortical site. Now, this is an article we published looking at plasticity in networks using mapping and magnetic source imaging. And what we show here is that, and I'm sorry, just not to belabor the point, but we look at the fact that we can see shifting of function with the magnetic source imaging, which is a better form than functional MRI to predict plasticity, which tells us when we can come back and do the second resection. Inoperable tumors. I think, sometimes we see patients who we think are inoperable, but that's because they didn't have mapping. And when you come back and you see that, and you do the mapping, you realize you can do more than you thought. So this was a study I published, somewhat controversial, of many cases said to be inoperable, where with mapping, I was able to show that I could get an 84% resection with mapping. So for example, a case like this, patient came to me, had a small resection, said to be inoperable, and we did the resection here. We were able to map it. We saw no function here, no function subcortically, and I was able to get all the way up underneath here and do the resection. This is where you see another case here where you see a multicentric GBM. The patient was told this is inoperable, had a biopsy because this was a functional image, fMRI, that was done outside, said to have activation here, so you could not do a resection here. We did the mapping. Here's the floor of the temporal fossa, vein of Lebet. Here's where the biopsy went in from the outside institution, and then both of these sites were negative on mapping, and I was able to do the resection here. So the mapping, I think, can be very useful. It can take something that you think is inoperable and turn it into operable. Okay, one of the final points I'm going to make, and then I'm going to show you, just to finish the talk, some extent of resection data that's very exciting, that points out how valuable this is. This is, when I was certainly in medical school, I was taught that you could not resect Broca's area. This is the original brain that Broca described. And the reason why the patient had an expressive aphasia is because of the subcortical injury to the inferior frontal occipital fasciculus. Remember, I pointed that out. But Broca didn't know that. This was the brain that was taken out of autopsy and MRI scanned many years later. I went back and looked at my example of how often I've resected Broca's area and showed that patients who didn't have a deficit beforehand did not have a deficit afterwards. In other words, any patient who had a deficit afterwards had deficits beforehand, except in one patient who had an ischemic injury from the resection. So the point being is that we can do resection of Broca's area now. Here's an example of that. Sylvian fissure. Here's the tumor. This was speech arrest. Here's the motor strip with a strip electrode. I'm going to now remove all this. So I'm going to remove speech arrest. And sure enough, the patient after surgery will have the ability.
Can you count from 1 to 10?
You may be able to hear this, I don't know. You can see she's dysarthric,
4,
has a facial
5,
droop,
6,
but is able to
7,
count.
8.
So the point is, and this is based on a study we're about to publish, showing that patients who have surgical resection of Broca's area do not have Broca's aphasia. Why? because Broca's area, like the supplementary motor area, is a planning area. It's only useful in planning motor speech. How do we know this? We've done some very sophisticated intracranial recordings with grids. We've shown that when Broca's area is active in patients here, they're planning to say what they say when the motor cortex is active here. So you see, the point is that Broca's area is active before the motor cortex is active. And when you look at this very clearly, you see very nicely that when patients speak, Broca's area is silent. When Broca's area is active, they don't speak. So you can remove this, just like you can remove the supplementary motor area and still not have a permanent deficit. It's a very useful finding. And then finally, and I'll conclude with a couple of slides, I just wanted to show you some really great data that we published recently on, we're doing the same thing for low-grade gliomas. This is for glioblastoma, but I think it's important. You know, years ago, I showed that extent of resection is important in outcome for GBM. Many groups have shown this, but unlike the original report out of MD Anderson with 98% resection is the key, we showed as you get much over 78% resection that you still make a significant difference in outcome. So it seemed like we were basing extent of resection on how much of the contrast enhancing tumor we take out, how much of the contrast enhancing tumor. But what about the tumor around it? What about the flare? Does that make a difference? And again, if you look at all the studies and you look at the relative risk of mortality, you can reduce it significantly, even at 2 years, if you do gross total resection of contrast enhancing tissue. But what about nowadays? What about now that we know about MGMT? What about IDH mutation? Is this important? And so we went back and published this data. I would strongly recommend you look at this. This is from a JAMA Oncology article in February 2020. Huge series, over 1,300 cases where we went back and looked at GBM. And we looked at the molecular classification. And what we found was very profound, very important. And what we found for all of these patients who are IDH wild type, regardless of MGMT status, who got Temodar as part of the STOOP regimen. And you can see very nicely, you would expect these were typically enhancing tumors and methylated, mostly half and half would show methylation, half would not, all IDH wild type. And we looked at the percent of non-enhancing tumor resected. And what we showed was that early on, if you don't do much of a resection of the contrast material, like 20, 30%, you don't make much of a difference in outcome. When you get onto this curve, it's pretty flat. We showed that over 78%, we start to see a benefit. And this is where we see the greatest benefit. But now, what about out here? What about beyond the enhancing tissue? And so we saw that in this patient population, who were IDH wild type, who got Temodar postoperatively, we had this survival curve versus this survival curve. What was the difference? The difference was this. So if we treated a patient who was wild type with Temodar, regardless of MGMT, who had a complete resection of all of the enhancing tissue, and we left less than 5 cubic centimeters of the non-enhancing tumor, look how much better they did than these patients here. These are the patients who never got Temodar because of their age. So if I break this out, you don't give a patient Temodar, they're not going to do well. But in this group of patients, forgetting the mutated type, because they do better, but the classic wild type patients who are less than 65, they are the ones, if you get most of the flare out, they're going to do the best. And look at this median survival, way out here, nearly 4 years with the stoop regimen versus those patients who are over 65. They didn't do as well. And patients who had more than 5 cubic centimeters of flare remaining, they didn't do as well. So we have to rethink this strategy. And we went back and compared it to all of the glioblastomas in Ohio and showed that they were able to validate this if we looked at the same extent of resection with flare. So bottom line is, for glioblastoma now, especially under 65, a maximal resection doesn't mean just contrast enhancement. It means non-enhancing tumor as well. Very important concept. Okay, so I will stop talking there, Edgar. I think that gives you a very nice kind of idea about all the things that mapping can do for you, how interesting it is, how exciting it is. And hopefully all of you in Colombia will embrace the technique and strive for the greatest resection safely as possible.
Thank you very much, Dr. Berger. It's a pleasure for your beautiful presentation to understand a little bit of these complex techniques. I just want to show a couple slides just to let you know that even that we haven't been there with you, we have tried, all your publications have inspired us to do all these mappings the best way we can. We don't have yet very good awake protocols for it, but for motor mapping, we're starting doing this stimulations, cortical and subcortical stimulations. And you have inspired us also to do our own protocols for doing stimulations, cortical radiological mapping as well. I just want to invite you. I hope we can meet up in the next WFNS that will take place hopefully next year in Bogota. So thank you very much, Dr. Berger.
Thank you, Edgar. I appreciate it. Very nice to spend time with you.
Absolutely. Thank you very much for your time. I know you must be tired and
well, for me, it's I think it's only 6 o'clock here. Maybe 8 o'clock for you?
It's 7 p.m. actually.
Oh yeah, it's 5 o'clock here. I'm sorry.
Yeah,
2
hours ahead. Yeah. So thank you very much. I will be texting you. So hopefully after this pandemic, we can meet up. So we can arrange 1 week or something to learn, take a look.
Well, we should do a case together. I will come there. We'll do a case together.
Absolutely.
And in the meantime, if you have cases that you would like some help with, send me the pictures and you and I can communicate how we can do this.
Thank you.
And, sometimes, some occasions, we can have a Zoom from the operating room and you can be doing a case. And if you're having some issues or questions, if I can know when you're going to do it, we can be available to talk.
Thank you very much. That would be awesome. I really appreciate the way you are so kind and to have better communication and share all this information. It's really useful. We're trying to improve every time. Sometimes we have some barriers, limitations to get this in the best way, but with you, absolutely, I hope we can get better and better. So thank you very much, Dr. Berger, and again, congratulations for your your tenure as a chair. It's impressive.
Well, I'm going to keep going. I'm not, as long as my hands are steady, I keep going.
I'm pretty sure of that. So,
Okay, thank you very much, and I look forward to having you visit with us and say hello to all my friends in Colombia, and stay well.
thank you very much. You're also welcome here anytime. Thank you.
Thank you very much, Edgar. I will be there.
Thank you. Bye-bye.
Okay, bye.
Entonces, ¿qué pasó? Que la gente quiere aprobar la